Hi there, welcome back to the podcast. Today I'm joined by Jim Campbell, Director of Health Workforce with the World Health Organization, and by our CGFNS CEO, Peter Preziosi. We're diving into health workforce issues and the programs and initiatives of the World Health Organization around health workforce development, challenges, and trends. We're going to talk about the state of nursing, the upcoming State of the World Nursing Report that's going to be published in May by the WHO, and a number of other topics related to workforce development. So stick around. This episode starts now. Across global health systems, health workers on the front lines of care delivery are carrying more on their shoulders today than ever before. Workforce shortages are increasing. Scope of practice is shifting, and skill sets are definitely evolving. In this podcast, we're setting the table for some powerful discussions with nurses, allied health professionals, regulators, tech innovators, and other thought leaders across the globe. Together, we're diving deep on the challenges and opportunities that loom large for recruiting, training, and equipping the health worker of the future. Welcome to Care Anywhere, the Global Health Workforce podcast, brought to you by TruMerit, formerly CGFNS International. Hi, everybody. Welcome back to Care Anywhere, the podcast hosted by CGFNS International. I'm Lea Sims, your host, and I am joined today by two amazing guests. We are going to be talking about nursing workforce today. Jim Campbell with the World Health Organization and Peter Preziosi, our CEO at CGFNS. Welcome, guys, to the podcast. It's so great to have you.
Hi, Lea.
Hi.
Great to be here.
It's great to have you. Let's start with introductions. Jim, if you'd let our audience know who you are and what you do and what you're working on right now, that would be great.
Yeah, indeed. So Jim Campbell, I'm the Director of the Health Workforce Department at the World Health Organization headquarters based in Geneva. I've got a fantastic team of people here in headquarters and around the world in our regional offices and country offices that are a team responsible to support ministries, governments around the world and partners in looking at the efforts, activities to develop, strengthen, maintain a health and care workforce that can provide universal access to health services worldwide.
Well, welcome. It's wonderful to have you. Peter.
Well, good day, everybody. It's Peter Preziosi, and I am stepping into year 3 as president and CEO of, and when this is published, this podcast will have a new name, TruMerit, Global Careers, Care Anywhere. Really repositioning the organization from a lot of our historical work around migration of predominantly nurses coming into the United States from low-resource countries to really support the global health workforce. Very pleased to have the opportunity to work with Jim. I've worked with Jim for quite a number of years. He also provided me an opportunity at the World Health Organization before I came back into now TruMerit. But there's a lot to be done around the world, and we're here to support other international and regional organizations as they are helping to support the global health workforce. Absolutely. We're super excited about our new name and the new brand that we'll be rolling out by the time this episode hits the air. So I'm excited to talk about that as well if we have time. Let's talk about some of the initiatives you're currently working on, Jim, such as the Global Strategy on Health Resources for Health, the Workforce 2030 initiative that you're part of. I was looking through that report just the other night. It identifies 4 objectives that it would be great if you could expand on for our audience if they're not familiar. Optimizing the workforce through evidence-informed policies, aligning education, employment, and investment, building institutional capacity and partnerships. That's something we're super passionate about as well. Strengthening data for monitoring and accountability. What can you tell us about not only the objectives, but the work so far on those?
Yeah, so congrats both on the new name. Great to be given an early teaser on some of that. TruMerit. Sounds like John Wayne movie of some description. It's
True Grit. Yes, that's
so look forward to learning more about that either during the podcast or beyond. The strategy, the global strategy. So this runs from 2016 to 2030. a 15-year strategy, and that's aligned with the Agenda for Sustainable Development 2030, the sort of the UN agreed, UN General Assembly agreed, heads of state level consensus for what to do with the world we want, the future of the world we want, back in 2014, 15, 16. So the request at that time was, okay, so now we've got an overarching socioeconomic development framework. How do we impact on gender? How do we impact on education, health, women's empowerment? What are we going to do then around what's the health and care workforce that we need to reach these very ambitious approaches for universal education, universal health, universal protection? And so we set out at the time an 18-month process of consensus building, looking at the evidence, engaging with countries in all elements of the world to sort of say, okay, well, what are some of the core things that all countries have to do? And exactly that, as you said, we ended up with 4 objectives, very much looking at the existing workforce. The first dollar, the first investment, today's workforce. Make sure decent work, protection, optimizing, developing their skills, ensuring they're coming further. Second one, what's the future hold? What's the workforce for tomorrow? What do you need in the future? How do you build your education pipeline? How do you look at that change? How does technology influence that? What about burden of disease, epidemiology, how do we respond to the global pandemic, for instance? Putting public health back at the center of our thinking. What's that future workforce? And as a result, have you got the institutional capacity to regulate, to steward, to license, to accredit, to manage, to protect the public? And what's your underlying data and science to drive that? So every country around the world, irrespective of geography, of income classification, has got to be doing similar governance elements of it. And now so that's 2016 that was developed. Now we're 2025. It means we're coming up to the 10-year anniversary. And it's gone so quick. My hair's a little bit grayer. I've got a few more pounds on me, but that 10 years has gone so quick. And I've had some fantastic collaboration with Peter, CGFNS, the former president, the very famous Franklin, around some of this delivery of the work. And in a couple of weeks' time, first week of February, the executive board will be taking a first discussion of that 10-year review. Where are we? What progress have we made? What are the issues? What's happening? Are we making the progress that we expected? And of course, COVID was in the middle of that process. 5 years ago now, 2020, then into the pandemic years. So we're a little bit behind where we would like to be at 10 years, but there's still huge cause for celebration. But a right point to have an appropriate reflection. And that's what the member states in the WHO executive board will be doing in the first week of February.
Hey, Jim, given a lot of the geopolitical changes that are happening globally, there's been a shift around more isolationism, nationalism that's occurring. How has that affected some of the collaborations with you? I know that we find the work that we're doing, people are still highly engaged when it comes to health and the public good around health. How are you experiencing that?
Well, with January 2025, everyone's looking to the New Year's resolutions. What are we going to do? But we're also looking back on 2024. The record years, a year of records being broken, more elections, more people voting than ever before. Climate change, global climate change, increased, the hottest year on record. All these different things that are coming through. And absolutely, there has been changes around the world in the politics, the governing bodies, the governing parties, and that will continue this year. Major elections coming up in many of the G7 and high-income countries and elsewhere. So, but WHO and the United Nations is a member state body of WHO, 194 countries. So there's continuity. There's not every country has gone through electoral change. There's continuity. There's experience, there's perspective, There are partnerships coming through, and there's real, there's a lot of continuity. You get fresh injection, new energy from new political parties being elected, but you still got stability in the continuity from the other member states. And so the process continues accordingly. Obviously, at your side of the Atlantic, you may be looking to the inauguration and thinking what changes that may be. When we're looking at 194 countries, that's just one member of many, as strong and as influential as it may be. And so what's the core? It comes back to the public purpose, the public good, the constitution of the organization. What are the key things we're looking to achieve in this next cycle? The consensus still is there. We're seeing a huge agenda item at the Executive Board in the World Health Assembly in terms of major topics around maternal health, maternal mortality, non-communicable disease, public health, emergency preparedness. But we need a workforce for every single one of those themes, irrespective. But there's an awful lot of consensus building in this diplomatic exchange, the governing bodies process. So, I'm a very positive believer in multilateralism. That it survived through decades. It has its up and downs. It has its moments. But multilateralism still, everyone disease cross borders, climate crosses, change crosses borders, disaster impacts across borders. And so there has to be a level of multilateral solidarity and support to these endeavors.
It's not a quick process for that reason. I imagine it reminds me of the saying, if you want to go fast, go alone. If you want to go well, go with others. And so I imagine this train moves a little more slowly when you're consensus building. You mentioned the pandemic disrupting the 2030 plan, obviously, but I imagine it exposed some things. It shifted some assumptions. It certainly impacted, as we all know, global shortage. Accelerated adoption of telehealth. There's a lot of things that we can say we learned through the pandemic. As you're evaluating coming up, you said you'll be at your 10-year mark and you're evaluating. How much has the pandemic shifted the objectives or the strategies that you'll be adjusting, or did it just shine a light on problems we were already aware of?
Well, I think with the benefit of hindsight now, as we're in 2025 and the reflection and a lot more scientific publications and evidence that's available to us as well, the pandemic, we must recognize the level of mortality and morbidity, the impact on the world absolutely changed circumstances for lives and individuals, families around the world, and we recognize that. But there was also a lot of innovation. There was actions were taken. These were health became a decision-making priority of heads of state with their cabinets. It wasn't exclusively down with the Minister of Health. So it was elevated up to executive decision-making. Funding was put into health at levels that we've been calling for amongst the global health community for decades and decades and decades. Public health has been unfunded forever. But suddenly there was huge investment into the health challenges, to treatment, to testing, to vaccines, and the vaccine and R&D efforts. So there's huge innovation, huge leadership in the face of this collective challenge come through. It wasn't always equitable, and there are lots of opportunities to learn from that, but huge innovation. So if you look at that, we regulation of license, regulation of scope of practice, bringing students into the workforce, bringing retirees back into the workforce if we look at our workforce dynamics, clinical guidance and guidelines to people who are at the forefront of the response, new discussions on PPE, et cetera, et cetera, et cetera. Huge innovation. And we want to keep that energy going, the very positive benefits into the next thing. And so there's this acceleration of digital tools, digital engagement, digital technologies, hybrid meetings, all these elements of the workplace, very positive. On some of the other challenges, though, what's the negatives of things? We've seen this scramble for assets, this scramble to respond. Not always equitable, not always ethical in terms of some of the decisions that may have been taken. Again, especially with the hindsight of reflection. And there have been many reviews and investigations, parliamentary processes to look and learn from this. And decisions were taken at the necessary decisions with urgency, with not all the evidence available, but in hindsight, some of those decisions can be challenged and say, well, we shouldn't maybe do that again in the future. So how do we learn from some of that? But financing has become a major problem. We've overexpanded. Debt has increased. Many countries now, debt payments, debt servicing greater than the share of payment on health and education combined.
Yep.
That's worrisome, because it means we're not getting the investment into education and employment in the health and care economy. And this is having substantive impact on the overall strategy to 2030. We're seeing people continue their investment in education, graduating people for jobs, but then there's no budget to put into generating those jobs, paying wages because of the debt crisis. So that's really problematic, because that's very much a negative impact coming through.
Yeah, Jim, part of our new positioning in TruMerit is to really look at care model evolution. So we pulled together a task force late last year to look at safe staffing guidelines through new models of care. And it's an interdisciplinary group. They're just getting ready to assemble themselves and think about some of these new models that are emerging. Virtual nursing has been used now here in the United States. I know they've got an excellent model in Portugal as well. And in fact, we've started a point of care test in Rwanda with the Society for Family Health and advanced practice nurses, where we're equipping them with a remote patient monitoring device to support them in keeping patients in villages in rural areas of Rwanda, and helping them to treat them out in the community rather than having them go into travel where they don't even have the transportation to go into a hospital for more expensive care. We've got about 100 people that have gone through the program right now. We've got 5 villages that we're working with. We expect that the findings will be preliminary findings in the next couple of months. But these are the types of things that we need to be looking at around the world. We've been talking with Brazil, Ghana, India, because there are opportunities. Now, looking at this just individually, and you brought up the issue before. Every country is different. But what can we do to provide the support and tools to the global workforce, thinking globally, knowing that healthcare is really local? So that's something that we're looking at when it comes to digital health tools and supporting the workforce and getting them prepared to be able to work with these technologies, whether it's telehealth, new ways of looking at care delivery through artificial intelligence.
Well, this comes back to Lea's point and Lea's question in terms of what we're learning from the pandemic on this overall strategy. I mean, what we knew was some of that early work on e-health and m-health and telehealth.
Right, m-health.
Huge acceleration through the pandemic as we suddenly realized, well, what happens when you can't go to work, when you can't be interacting, when you've got a screen and put in place the social measures to protect against transmission. So we've really accelerated some of that digital tools and technologies, their uptake. And more importantly, the technology was already evolving. But we've put more money into making that technology work with the communities that we serve, the populations that we serve. And so you're seeing, again, this acceleration of digital wearables, digital tools, technologies, remote consultations, your example in Rwanda and elsewhere. And that's really come through. But then the challenge becomes, okay, that's wonderful, wonderful, wonderful. We come back to, though, the strategy, which says in the Objective 3, as you were saying, Lea, okay, what about your institutional capacity to do this? Because you still have a stewardship responsibility to protect the patient. So how do you regulate and license a professional interaction with a citizen of your jurisdiction when that professional is in a completely different jurisdiction under a completely different set of licensing rules and regulations?
Yep.
And so technology now enables that to happen. The e-consult or the tele-consult, whatever you want to call it, and the terms vary around the world in different languages as well. But, where's the protection of the public? Who is regulating that promotion? What's the licensing laws, regulatory frameworks of the country? Because the way that and this is going to be more so with augmented intelligence or artificial intelligence, which is going to support our clinical workforce in their diagnostics, in their prescribing practices as a support tool and a support function. But who's protecting the relationship there to protect the population who hasn't got the same access to information, and the asymmetry of information still pervasive? So this is, again, we see huge opportunity and innovation coming through some of the pandemic experiences, but you've got to bring that back to the practical application of those tools at scale.
We've had a hard enough time figuring out how to do telehealth across state lines in the United States. I mean, it's been a big battle just being able to treat a patient in another state. I imagine the governance of that across countries is even more nuanced and complex problem to solve, as well as reimbursement, being able to get paid for those visits, as we all know. So, Peter, you were saying.
Well, I was going to just comment on, you were, talking about standardization and the work that's been done at the World Health Organization and the Health Workforce Department around universal health coverage, and a competency framework that was developed there, along with other frameworks in health emergencies, rehabilitation care. In fact, we worked with the rehab area of WHO and their rehab competency framework as we developed global certifications in rehab care for nurses, allied health workers, and assistive personnel. We're beta testing those global certifications this first quarter of 2025. But those competency frameworks that have come out of the World Health Organization have been extremely useful for us as we are developing the examinations using those frameworks and then creating the practice standards that are coming out of those to be able to test people's competence.
Yeah, absolutely. Which, speaks to career portability and mobility for health workers. Let's talk about the one of the other initiatives you're working on, Jim, which is the Global Code of Practice on International Recruitment. That's certainly something that CGFNS has historically been tied to, had an interest in, recruitment of health personnel. And then the other one that I know you're working on, Global Strategic Directions for Nursing and Midwifery. What's on the horizon with those? Can you talk about the objectives of those two initiatives and what you're doing there?
Yes, indeed, Lea. And these are also agenda items at the Executive Board and the World Health Assembly. So countries coming together again to look at this issue. The Global Code of Practice is now 20 years, 2004, when first discussed in the Assembly as an issue during the prior Millennium Development Goal era, where we were looking at them, recognizing at that time that migration of health professions potentially has always happened. It's always existed. Migration has been there throughout the centuries. But that during that particular moment in time, that may be therefore having the positive elements that always existed, but some potential negative impacts on health systems from the source country, who were losing their doctors, their nurses, their professions from low-income countries to high-income countries at a scale which had been sort of this accelerated scale at the time. And so the need to therefore recognize, let's have a bit of responsible behavior around the world to do that. So the 6 years of negotiations, eventually then in 2010, a code of practice was adopted in the World Health Assembly. And so now we're 15-year anniversary of the code. And there are two processes. Every 3 years, member states report on what they're doing to implement the code. And every 5 years, member states review the relevance and effectiveness of the code and whether it's achieving its stated output. So we've got, we're on the 5th round of reporting by member states and the 3rd round of review by member states. So it's a really exciting. We've got all this data plus this external review at the same moment in time. A new report, it will be on our website by the time you've published this podcast, from an expert advisory group. It's co-chaired by Canada and the Philippines with member states from around the world. It's had reviewed evidence from around the world, including evidence from yourself as CGFNS, now as TruMerit. They looked at evidence from countries, from institutions, from experiences, and looking at some of the challenges going on. And what are the big picture messages out of this? Migration, again, during the pandemic, accelerated and continues to accelerate. And so around the world, we've got ever increasing numbers by head count, by total, in terms of people who are working outside of either where they were born or where they were trained. And that's no bad thing in and of itself. This interconnectedness, this worldwide framework comes back to the whole discussion we started at the start: multilateralism, the need for consensus among countries, people working everywhere. Some of the high-income countries, more than 100 different nationalities working in their health systems, as doctors, as nurses, as pharmacists, et cetera, et cetera. So it's a contemporary issue that we have to think. But we're still seeing that some of the practices around recruitment, some of the monetization of those recruitment processes are targeting countries where there's an aspiration to migrate in those countries, but they're very much being targeted to say, we'll facilitate your journey, your migration pathway, but there are fees, there are payments, there are requirements that you have to have to be able to do that, to cross borders accordingly. And some of the countries then are losing that experience. These are not just graduates who just graduated. These are people with 5-10 years experience from the health system. Right. These are senior clinicians, senior professionals who are coming out and then diminishing the capacity. It's not somebody with just 12 months experience that's just coming into an early career. And so what are we doing about this management? And then the reality, other evidence, if you look at some of the high-income OECD countries, who are just not educating enough for the demands that they have today. Aging populations, long-term care, non-communicable diseases. And the graduate numbers going down. The OECD has just published an updated report in December 2024, looking across all the countries. There's fewer 15 and 16-year-olds who are putting their hands up to say, I want to be a nurse, I want to be a doctor. It's going down. The pandemic is scaring them away from these professions. And so the number of students aspiring to be future health workers going down in high-income countries. The number of applicants, not just the number of aspiring students, but the number of applicants in some senses going down. The number of graduates going down. And yet at the same time, aging workforce. More than a quarter, if you look at the population demographics of the workforce in Canada, Germany, elsewhere, US, more and more people clustered in the next 10 years will retire with no equal number of people coming into the system.
And fewer practitioners moving into health education.
So you've got all these different variables and factors is sort of the combining to increase demand for international recruitment, international medical graduates, international nursing graduates, stimulating that demand from high-income countries for everybody in the global labor market. So migration is growing, is clear, and it's likely to grow even further. And then it becomes an issue. Okay, well, if you're not spending as much money on your graduating your numbers that you need for your workforce, and you're just picking a free good from the global market, is that the right strategy for the world? is that the right strategy for universal access to health services? Which is where we come back to the 2030 strategy and the SDGs. And the question has been asked, maybe it's not the right strategy. Maybe we need to be doing something different.
Right.
Yeah, no, I was going to agree. Jim, this is a huge concern of ours, around health equity and migration, if you will. And we have a certification program for international recruiters based on the WHO code. And we're right now evaluating that certification program to ensure that it matches to the new code that's being released. And does it have enough teeth in it? And furthermore, it shouldn't just be with the United States. We really need to begin to look at other countries. The Middle East, if 90% of that workforce are from outside of the Middle East coming in there to practice, what type of ethical recruitment is going on over there? These are things, that we need to work at the recruiter, employer level to really help to support the growth of that code as you're looking at it from the top level of the country ministries. So that's something that we really are taking a look at the first part of this year with our ethical recruitment practices.
That's excellent to hear. And obviously, this has been one of the areas that we've had over a decade of collaboration with CGFNS on in terms of your role in credentialing, recognizing, certifying people as they take up and explore an opportunity for career and career development in the United States and elsewhere. So, we need more people, reaching the best practice standards that are necessary in this. And that's not common everywhere around the world at the moment. There's a lot of commercialization of this migration movement, taking the opportunity to facilitate the movement of people across borders into different jobs. Now, and you mentioned the Middle East, and there are many others like that. And there are other countries where they just don't have the education capacity, small island states, and they will always be dependent upon international recruitment to fill their positions, or the transfer of people to other jurisdictions for their education coming back into another jurisdiction to practice. And that's positive. That's great. We want to facilitate those things, but also just limit some of the behaviors which are having a negative impact on universal health coverage elsewhere. The same then, this global migration, doctors, nurses, other occupations, care workers, what we're seeing there is more and more care jobs not being filled, and therefore attracting licensed health professionals into non-licensed care work because of salary differentials, because of opportunities. So people leaving a low-income country, low-middle-income country as a licensed health profession to take up an employment opportunity as a non-licensed care worker. And these are some of the things which is, okay, you fill for one system as a care industry, but you really are diminishing another health system with a clinician.
You're diminishing the health worker if they're working below their licensure.
Indeed,
for a better income.
Yeah.
So,
indeed. And so, how do we look at new? Every country needs a health and care workforce that is related to their population needs. So we all have the same ambition, but surely there's better ways, smarter, more efficient, more effective ways of looking at the global phenomena and cooperating, co-investing, co-working on these issues. And that's the same then we come to nurses, because you mentioned earlier there that the other agenda item on nursing and midwifery, the biggest occupational groups in the world in terms of our clinical workforce, having an impact across just about every technical service area, and increasingly in research and development, leadership, systems, public health, climate health, mental health. It is nursing, midwifery, having this huge range across health services. And so really, this has always been an occupation since 1948, when the WHO was first opened. First decision in this in 1949 to strengthen nursing and midwifery around the world at that moment in time. At one stage, we had more people, over 1/3 of the WHO workforce, working on nursing and midwifery in that 1950s period. That was the biggest single technical program of WHO, developing the nursing and midwifery capacity worldwide. Always been an occupation of interest. Where are we on that? So we're 2025, the strategic directions for nursing and midwifery are under review. What do we do with that? The recommendation from chief nurses all around the world, chief nursing and midwifery officers all around the world, is that we need to extend this to 2030 and we need to accelerate action on that. And then we've got a wonderful second edition of the State of the World's Nursing Report to be published.
I was just about to ask about that. We're excited
alongside
to see it.
That. It's so exciting. We had a fantastic session, 2 hours yesterday. We had a meeting with the co-chairs this week. We had a 2-hour session yesterday on the zero draft, the first internal sort of review of all the data coming out of it. It is so exciting. So it really is giving us this phenomenal appreciation of where we are today. Imperfect still, because you can never get perfect data in health, no matter what you do. But right. As a workforce scientist, there's a bit of it loving to play with. Look at the numbers. Look at the issues. What do the numbers tell us? This very, very a report that's really going to make a big difference and encourage, hopefully, some of these global discussions and the partnerships. Recognizing that production education capacity around the world is different levels. The absorption capacity is at different levels. The co-investment that we need to help countries with less resources than high-income countries. It's the moment in time. It's not the moment for unilateral closing of the borders. It's actually the moment for global health to be opening discussions through multilateral, because there's so much potential learning from COVID, so much potential we could be doing to take action in the next 5 years to catch up from what the COVID disrupted.
For our audience, can you explain what the report covers and also when the first one came out, how long it's been since the first one to now this second edition coming out? I think around May, right?
We're scheduling for the World Health Assemblies in May, so we'll be launching just before the assembly. There's a couple of dates that we're thinking about, maybe International Nurses Day, maybe World Health Day. The last one was 5 years ago, 2020, and it was during the assembly, 2020, but right at the moment of the pandemic, as you know. But we had the International Year of the Nurse and the Midwife at the time, recognizing the work that needed to be done and accordingly. The core elements obviously is around what's first and foremost, recognizing the contribution of the professions, the occupations, to the ambition of the Sustainable Development Goals. So universal health coverage, health security, the health-related SDGs. And this is a workforce which is predominantly female around the world. The impact on women's economic empowerment, the impact on gender, the impact on gender equity. So if you get things right with the women in the workforce, the health workforce, it has all these other dividends. So looking at the contribution across the SDGs, looking at the contribution to different thematic areas, and just reassessing the evidence of the value proposition of these occupations. Why do we care so much about these occupations? Is because of the science, the evidence of their contribution to our lives, to our health, to our family's health, to our planetary health, etc. Then looking, what's the state of the world today as a result? What's the education issues? What's the migration? What's happening to employment? What's happening with pay? Are we paying our nurses and midwives properly? What are the differences around the world? What's happening with licensing? What's happening with mobility? What's happening with leadership and career development? So looking at all the facets of the working life of a nurse, the working life of a midwife worldwide, and then saying, as a result of which, what are areas where we're seeing good practice? What are some of the areas which trigger impact? So if there's certain things that certain countries are doing, and if we see 50, 60, 70 countries doing something similar, which has an impact on health outcomes, it has an impact on patient safety, it has an impact on quality of care, is this something that other countries should be looking at and thinking about reviewing, reflecting, and integrating in their health and care systems worldwide? So it's an evidence-based policy options for consideration, so that we, in the next 5 years for the SDGs, how do we accelerate action?
Jim, I think that your team, the Health Workforce Department, along with the chief nurse, done an excellent job of really pulling together experts from all regions of the world to really look at the issues that are confronting nursing. So there's that the data that's being collected, and what a great job the team has done on that. But alongside of that, really are looking at, where is the profession going? You've really convened some experts that really have a pulse on what's happening, not only globally, but regionally and within certain countries. So I think the report's going to really be a very useful one for organizations like ours to provide that guidance to really know where we should be putting all of our efforts and more focus to help to support the nursing profession.
I say this on almost every episode where we talk about nursing, that despite all of what we hear in the news and media about critical shortage and burnout, and all of those challenges are very real, there's probably never been a better time to become a nurse in history. Nurses have an increasingly powerful share of voice at the policy table, and our leading care model evolution in so many ways, highly sought after in tech positions to guide the development of patient-centric technology. And so I just think it's an exciting time. We're looking forward to that report coming out, Jim. I know CGFNS was a contributor in a small part to some of that data. So we're excited to see it and talk about it and make sure people are aware of it. We are at the end of our time. We had a couple more questions we could get to, so we might have you back, Jim, to talk about some of those other things. Thank you so much for joining us today. I'd love to get both of you your final thoughts. When you consider the global landscape for health workers, what gives you hope for the future? There's certainly a lot of challenges, but I love to have our guests land on in a hopeful place and talk about what gets you excited about the work you're doing in every day and about the future of that work. Jim?
Lea, one of the things, the State of the World's Nursing Report, the Code of Practice, the Global Strategy, all these pieces of work that we do in partnership with countries, we do with other agencies, non-state actors, academia, licenses, professions, etc. The workers themselves, and it's one of the privileges of the role that I have, is working internationally with so many different stakeholders on this thing. And I take real very much the excitement, the enthusiasm that as I'm engaging with people, that yes, there are always challenges. We know that. We know that. But we work in a diagnostic industry, health. We like to diagnose disease, to diagnose problem, to diagnose illness, and then, what's our intervention, what's our therapy, what's our guidance for the individual who has an illness or some sort of burden. So we're in an industry which is diagnostic. But actually, if we spend too much time diagnosing purely the illness part, and we don't actually celebrate the success, the agency, the voice, as you said, about the voice of nurses, the contribution, the excitement, and look at some of those elements of labor in our health industry. And how do we get that? And that just really is inspirational when I listen to people telling me their stories of how the work is being implemented at the national level, how policy guidance, the code of practice, protecting people who cross jurisdictions as migrant workers, being protected and being offered contracts of employment which protect their rights, being offered the same terms and conditions of employment as the domestic workforce.
Absolutely.
They're being offered the opportunity to contribute and have career ladders and development. So these things that get developed in this World Health Assembly in Geneva, this big bubble of ministers coming together, actually makes a difference to people's lives. And when we hear that and that testimony around the contribution. That really excites me. And that, again, inspires us to keep going. That's, this is a public health purpose, a public health policy with evidence-informed practice. That's what I get out of bed for.
Wonderful.
Yeah, I would say that what's exciting to see is the resilience in the nursing profession, the amount of innovation and entrepreneurship that's coming from nurses around the world in all levels of resourced countries where they're coming up with new ways of caring for patients and turning that into a business. It's pretty exciting to see some of these opportunities and innovation that's coming out.
Very exciting. Thank you both so much for joining us today. Jim, we'd love to have you back after that nursing report does come out. Maybe you can share some findings with our audience. For everyone that's joined today, thank you so much. We'll see you back next episode on Care Anywhere. That's it for this episode of Care Anywhere. Thanks for joining us. We hope you'll tune in for future episodes where we will continue these powerful discussions about our global health workforce. If you missed any episodes, you can find them at trumerit.org/podcast or by subscribing to our channel on your favorite podcast platform. Just look for our podcast logo or search for Care Anywhere to find us. Thanks again, and we'll see you next time.